Okay. I don't think I sufficiently embarrassed myself on my last case to help everyone to feel comfortable doing this. So I've brought this case in, which actually I do something where I break my own policies and protocols, which I normally follow to the letter from WVU. I'm trying to uh, to basically show where we do have in the real world we have to sometimes make sacrifices, and that's okay, and get everyone comfortable presenting cases, even though sometimes it means we don't look like we did everything perfectly. It's okay to not be perfect all the time. So one of the things that happened on this case was I ended up giving someone more benzos than I would have. I'm not sorry, more Suboxone than I normally would have with benzos in their system due to some of the COVID stuff that was going on, um, and then I I'm gonna tell on myself for that here. And to be honest, I was out of office, and it's part of why that happened. Um, so so the MAT questions that I've listed on this person are a little more mundane and uh, sort of, we the patient ultimately lost them to follow up. So it's sort of what could we have done differently and better, um, but also it's with the understanding the context. This is a case that was really squarely in the middle of COVID-19, trying to struggle with real world changes. Um, so this is not like what we would have been exact same patient 6 months ago. With before COVID, we would have been a lot more streamlined and easier to manage. So, so I guess a lot of what I'm looking for is solutions in the new world of COVID as well for some of the problems that come up logistically. Creative solutions. So, it's a 42-year-old white male with Medicaid that, um, um, well, actually, before I present his case, I'll read the questions that I have so you can think about them as we go through. So, what ways have other MAT providers developed to enable patients with busy work schedules to participate in MAT? So this patient left over saying his work schedule uh, made him not able to come. What is the minimum amount of participation that is acceptable? What I mean by that is, how far have folks at the Coates program, Morgantown, and elsewhere been willing to go to keep a person in therapy, especially in light of if their main reason for not staying in therapy is that they have to work, and it just doesn't fit with your schedule. The next question, conversely, what methods have been helpful during COVID to increase patients' desire to participate? Because for me, um, I think probably if the participation, if the desire to participate was high enough, they would have set their schedule up to work it in, uh, to have be in your program, even though they have a weekday work job. And the next question, are there cases where you think it's appropriate to create conditions that are more agreeable to the patient, but not the Coates model in the context of COVID? So, for example, we had, and in one of our older presentations and cases, there was a person who was on dialysis, and, they had to take care of an elderly demented person. They couldn't sit through the long, um, echo stuff. So we worked outside of that for them. But whenever you start doing it for people that it's just not convenient for their work life, it starts to get into uh, you don't want to go too far with letting everyone be outside the Coates model, even though sometimes you have to make those sacrifices, and COVID makes you make a lot more of them. The next one is the interface between methamphetamine and Suboxone use. So this patient that I'm going to present used both, and as street, and actually felt that they were addicted to Suboxone as an illicit substance. And so I was very curious what other providers thought about the interface between Suboxone and meth. Like, what is the street use? Is that a thing where, like, people are using meth with Suboxone the way that alcoholics smoke cigarettes, and they seem to go hand in hand? Is there some sort of combo use issue going on here that I'm just not aware of? All right, let's present the case. So, a 42-year-old white male with Medicaid. He's very, well presented. He's not covered in tattoos and sores, or he's got good teeth. Uh, he's doesn't appear to have really advanced comorbid polysubstance use disorder. He presents for treatment in April after he was following his primary care for diabetes, hypertension, obesity, erectile dysfunction, fatigue, and depression. Um, and he had, during all of that, they were trying some medications that weren't working. He told the primary care that he was addicted to Suboxone from the street and wanted off of it. And also um, some of his background with drug history, that he had been on Lortabs a few years prior, but that he switched from those to Suboxone Street, and that about 8 milligrams Suboxone Street will last for an entire week, something that he will reverse when he gets to me, that history. He stated that he had been feeling sick and was having a lot of highs and lows. And I did also report to the primary care that he was up very late last night building a shelf, and that he has trouble sleeping. And a lot of the primary care physician's focus was on just treating generic depression, and really didn't have any sense that this person is going to turn out, when they get to me, to have a polysubstance use history. And that late last night shelf building was likely methamphetamine. So the patient is taking mirtazapine just for sleep, buspirone for anxiety, venlafaxine for neuropathy, Viagra for ED, and then metformin, atorvastatin, glyburide, and lisinopril for his diabetes, hyperlipidemia, and hypertension. So he comes to the MAC clinic at the behest of his primary care for the street Suboxone use, where he admits he's had been smoking pot long-term since age 16, alcohol, first use at 16, but not a problem anymore. Oxycodone started at age 25, most recently 4 years ago, but have been up to 10 pills orally in a day. Hydrocodone starting at age 25, none in the last 2 years, up to 12 pills a day. Benzos up within the last year, and last use within the last week. And he's taken up to 3 to 4 pills a day, and did not know that that was not safe with the Suboxone Street he was taking, and reported that he had started meth 2 years ago with the most recent use 3 days prior, which actually was at the time of that primary care visit with the shelf building episode. So he reported his overall street use of Suboxone to me differently than to the primary care, with starting 2 years ago, starting at half a strip orally a day, or 4 milligrams a day, but then increasing it now to 12 milligrams daily. Nothing on the board of pharmacy. We did a drug screen. It has methamphetamine, benzodiazepines, and buprenorphine, consistent with his report of recent use to me. We had a big discussion about the dangers of benzos and Suboxone. He shared it wouldn't be a problem. So this is where I admit that we were doubling script durations, and I was actually going to be out of the office. So I ended up giving him 6 days of medicine, even though he had benzodiazepines in his urine on induction day 1. But I did actually ask for staff to call him back in a couple of days later, but that didn't work out. I'm about to tell you why. The very next day after he received the Suboxone, he went to his primary care reporting fatigue, fever, and cough, and he wanted to be tested for coronavirus. And that did turn out negative, but at the time, there was just an unbelievable amount of bureaucratic panicking about the fact that someone had been in my office for an induction and had been then potentially developed COVID symptoms. I think I would have probably been given a reprimand. It turned out that he actually had COVID or something, and it connected back to my office, because it was really in a very difficult time to be bringing people into the office. But I continued to do it, and fortunately, I was supported by my medical director, Dr. Brummage, who said that he applauded my willingness to take the risk and bring people into the office. Anyway, the night after visiting the primary care visit to get the COVID testing for the fever and cough, or 2 days after getting induced with the Suboxone 12 milligrams, which he reported to me he had already been taking his treat. His wife called reporting that he was hallucinating, having incoherent speech, and trouble staying awake. And it got reported also by I believe the wife, I don't know, it was documented by our staff that he had a blood sugar of 21 on the same day that I started him on Suboxone. Keep in mind, he was very alert, and that's why I gave the big story about how clean appearing he seemed when he first came into the office. So if he had a blood sugar of 21, it wasn't in the near interval or pre-interval before coming to the office for me 2 days prior. So maybe it was the night after I'd started him on Suboxone. But anyway, wife kept calling. She wanted to know if my Suboxone was causing this as a side effect, and she's reporting he's not able to talk with us because he's reportedly, somnolent and hallucinating. And we still don't even have the COVID results back yet for the COVID testing, so we don't know what's going on. But and I was off work, so fortunately, I have a very good staff that filled in for me. My behavioral health provider and recovery coach, both I think very skillfully navigated this series of landmines because they understood that they could not really speak with the patient's wife about the whether Suboxone is playing a role here. They just said, well, if he's having those symptoms, you'll need to take him to the ER. And the primary care did the same. But the behavioral provider was also able to even get a hold of the patient and speak directly to the patient, and reported to me that the patient did not even seem to be having the reported symptoms at the time of the discussion. He thought that the person that had the patient had was likely not somnolent and hallucinating, but rather just very, very fatigued from withdrawing from methamphetamine, but couldn't talk to his wife about it. So anyway, we told the wife to take him to the ER. She called EMS, and they came, but I think he refused to go. I don't have any details. I never got any ER note. I don't think he went. So there was a lot of, when I came back to the office the next week, there was a lot of people saying that it was a very frustrating and challenging situation. The wife kept requesting to get information about his treatment, and we weren't able to give her anything. And I think that was the right thing. Apparently she even at one point asked multiple people if she could be involved, even before all this hallucination stuff during his day one consent. And so there was a lot of staff challenges we had, and a lot of time spent on, very, very tactfully handling a very, very concerned wife that was not being made aware of what's going on. The patient had actually specifically requested that she not be involved on the consent. But the patient never really talked to me much about what the situation with his wife, and whether that was a major thing driving his desire to join our program.
It was.
Oh, okay. Bailey says it was. Okay, so maybe wife was pushing him to come here all along. Anyway, 7 days later, he's doing better. But he's still sleepy all the time. So primary care drops the Remeron, and we tried to call him in for a random a second time, because the first time we tried to call them in 2 days later, they said too sick to come in, can't come in. So we didn't get a 2 days post-induction random, but given all of the things that happened with his staff, and it was COVID, and I was out, and he was able to come in 7 days, we decided not to count it as a failed random. We got him in especially since when he came in the second time, the wrapper count was one off, and although the urine drug screen showed methadone, benzos, and PCP, the send off ultimately showed nothing. It was just BPG. Looked like it was taken properly. So I think the levels are here. There's like the bup and norbup. Although I will say that the ratio is really rather quite high for the Norbup. But I tend to not think much of this. If someone thinks this means something, I'd love to hear what what their interpretation would be. But I interpreted it all as, well, it seems that he has sobered up and stopped methamphetamine and benzos and is taking Suboxone correctly. So I say, I felt like we had confirmed that the send-off drug screen was appropriate, that benzo use had resolved, and he was just dropped into the weekly therapy group, and all of this very dramatic induction drama left behind us. He started coming to video calls weekly for 5 straight weeks. He was stating he was sobered every week. We only called him in one more time for a drug screen about 4 weeks in. It was even sent off for comprehensive, and it was totally negative except for buprenorphine. But then right after that, he said, well, I have to work all the time, so I can't participate in MAT anymore. I said, I can't, I don't have weekend offer, but I could meet you even late in the very evening, like at the end of my clinic day. I want to work around you. He's like, no, I can't do that. I said, we actually have a lawyer on staff from legal aid. He's not really on staff, just a legal aid fellowship, that he actually, like, he can write letters and even, letters to employers or to the court that they have to make reasonable accommodation for patients to be able to participate in MAT. But the patient just seemed very disinterested in anything we offered in terms of, well, at least those two things. He wasn't interested, and he just did not come back the following week. And my recovery coach called him and said that he just confirmed that he wasn't planning on coming back over. He wasn't able to participate in the program. So that's sort of the whole story. Sorry, it's a little bit wordy. I guess rather than answer specific questions, I'd just be curious to hear people's thoughts. What did I miss? What could I have done better, just sort of in general?
Thank you so much, Dr. Morrison. That was excellent, as usual. So any thoughts, questions, comments for Dr. Morrison in the case?
Mitra, I have a question. This is Jennifer Boyd. This is a really interesting case, and the questions that you laid at the outset, they're so pertinent to our program as well. We're really seeing people struggle, and some people struggling related to working. And so I'll be curious to hear discussion about that, because to me, it seems that our program, and particularly our case manager, Amy Lively, who's on the call, really offer a lot of accommodations for people who are working. And we've had some people fall off because of that. But my question, it's so interesting to me about the wife, and I wondered if you guys picked up on why he didn't want her involved. But then my other question for everybody is this question about the urine drug screen versus the confirmatory test. How common is that to have a false positive on the screen for PCP, meth, and benzos?
It's very unusual to have a lot of false positives. So I don't know, from our experience, sometimes we do get like false positives, but false positives for like three, more than 2 drugs is kind of rare for us, at least. So I don't know what's the make of of that. Another thing is like 2 questions I want to answer, Dr. Morrison. I mean, you did a wonderful job given this kind of difficulties because of COVID-19, and everybody was panicked, and it's very hard. And a lot of patients are kind of they cannot follow up as regular, routinely, and they have no access to treatment. So the relapse rate is so high, and we transitioned very well. I'm pretty sure Laura can share more experience on that. Two questions I want to answer is, the first question is like about a co-addiction of buprenorphine and methamphetamine. So this is the story I heard a lot from my patients. So a lot of people, they use Suboxone or Subutex off street, try to get off opioids, which is a good thing. That means Suboxone, at least has a reputation of being a treatment medicine and helping people get off opioids. So a lot of people just buy off street, try not to use anything else. It could be more harmful, definitely. But unfortunately, Suboxone, in between this, when people cannot have Suboxone, then the withdrawal is miserable. So a lot of people use methamphetamine in between to help them with withdrawal. So I believe there's a misconception, like basically, you use one drug, you can just counteract the withdrawal from the other drugs. So I believe people may use Suboxone to help them fight withdrawal from methamphetamine. So that I heard that stories as well. So I just want, from DDU, from our co-clinic. So we saw, a lot of patients reported that. So they use one drug, try to help them, deal with withdrawal. And methamphetamine is so cheap, it's so easy to get. So the big problem for me is like when patients ask you for Subutex, that's probably a flag, because the street value for Subutex is so high, then they can sell Subutex to buy methamphetamine or other drugs. So this is also commonly reported in our population. So the second is like, what's the minimum acceptable attendance for patients in MAT? I guess my opinion, this is a personal thing. I think there's no minimal time. I guess so what do we do for this population? I think MAT's MAT, medication assisted treatment, is harm reduction at least. So we're trying to reduce harm. So the problem is, are we doing the right thing by just prescribing them with 6 days of buprenorphine, Suboxone, but we cannot see them. We have no choice. And in this case, the prescription is doing good or bad. So if I were you, definitely I would give 6 days, no doubt, because I think in this case we have a lot of patients we just call in prescription for them just because they just cannot attend a group or attend a Zoom group for whatever reason. So we're more generous during COVID-19 time. So I think harm reduction is a harm reduction, and we are doing our best to reduce harm. But for if they cannot attend for whatever reason, if they can stay in the program, that is a success. Of course, we don't want people to divert. We don't want people to use other drugs at the same time and to be dishonest in MAT groups. However, I think as long as patients can stay, if we can, that gives us a chance to work with them further, to provide some kind of help. So I guess code is code, and we do have a group practice here. We do have rules, a lot of rules, but difficult times, we may have different rules. And also individually, every patient should be treated differently. So that's my thought. Yeah.
Some things we've looked up too here is having people who can't do clinic for whatever reason. And maybe if we have a doctor or a prescriber that is able to take them on individually, we'll kind of use the Coke clinic model, but you're only using individual therapy as opposed to group therapy. So for 90 days, they still check in weekly with a therapist. They still do those types of things. We graduate them to bi-weekly and monthly. But it is trying to still treat not just from the harm reduction model, but also the underlying characteristics as to what could be feeding the addiction as well. So I think we can get as creative with it as possible and as ethical as that each situation needs.
At the same time, I think treatment, it's important to help people look at kind of a life balance. And if you are working 6 days a week, 10 hours a day, it's going to be hard to really integrate a recovery lifestyle into that. And so some patients need help with doing that, and the structure of the program can help them. I mean, it is nice to be able to have an evening clinic or evening hours for people who are working, because we've often heard patients say, well, what am I supposed to choose between my work and my recovery? And in fact, some people do have to choose that. And when I see people choose their work, as the saying goes, you know, you lose what you put in front of your recovery. They often lose their recovery because they can't maintain a job in active addiction. And that's not an easy choice. And I never, you know, kind of pretend that that's like an easy choice, but to achieve some kind of balance with recovery really having to come first is, you know, something we're trying to help patients with.
So we've had some similar issues in our group. And in particular, we have a young gentleman who is recovering from heroin, but now since COVID, he became the only breadwinner in his family, and he had to go and work. And it was also, and not only did he have to work, he worked out of town. And so it was very difficult to get Zoom meetings for him, just to meet, just to check in every 15, 20 minutes. So what we did, we kind of came up with a plan with him, his mom, and a treatment team. And whenever he can touch base with her or touch base with us, we just kept him engaged that way. We didn't want to stop his Suboxone because we knew he would relapse. I mean, his sister just died of overdose last year. So he's pretty high risk. But it has been tricky. And so far, he's been okay. But I think he might be the exception to the rule. Is for a lot of people, if they're not in active treatment, especially early on, it's very difficult just to maintain a life, much less a job. But yeah, Ryan, we've been doing all kinds of things since COVID. We have some people who moved completely out of town. And so we had to do everything via Zoom. And sometimes they can't even make those meetings. But they're committed. They would come in for urine drug screen or would do one at a lab closer by them. And we've been working with them, knowing it's just a bad situation.
I wonder too what even this individual's kind of motivation for change was with everything you offered him from your whole staff about evening hours and different things like that. I mean, was he even ready for recovery at this point?
We had a patient last week, and he actually participated in the groups, Zoom group, a therapy group, and a medication group while he was working. So he, I mean, and that was last month. And then he, of course, he has a very busy schedule. He's been working like 7 days a week. So, but we did not. We told him he has to participate. So he missed one time. We pretty much asked him, required him to make up, and he did that. And now we did our best. Luckily here in Morgantown we have an evening group, Monday evening. So that is like after working hours for him. We finally found a slot for him, and he has been transferred to that group, and he's very happy now. So yeah.
John, was there something you wanted to comment on?
Sure, and you might hear my mouthy cat in the background. It's just so interesting to me because, and I just started with working in the program about 3 months ago, so I had about 2 weeks before the COVID shutdown, and I've of course shadowed in our program and up at WVU several times. To me, the requirements of the program dropped so much when COVID started. The fact that they don't have to come in, they don't have to spend the better part of a morning. It's in some cases and we only a couple weeks ago started doing Zoom group for our medical visits. We were doing individual visits, and frankly, hearing what you all are doing really has helped us to go forward with Zoom medical group visits. But at any rate, it's been sad to me and frustrating that people are having trouble even with a very short Zoom call, and whether they work or not. And in some cases, I can understand that the working, sometimes the access to a private space or to the ability to Zoom in, or we're even doing phone calls. So to me, there's a bigger issue of the COVID crisis that I feel like we're really struggling to keep people engaged. It's been difficult.
Nick, I saw you had unmuted. Was there a question you had or comment?
Yeah, sorry, I had troubles. So you said he couldn't get off for work. What kind of industry was he in?
Construction.
Okay, so there are legal protections, but if we consider the kind of social environment in which those guys work, if you take off to go to the doctor, even just a regular doctor, it's not going to be seen well. I mean, a lot of those guys are day laborers. So that needs to be considered in a greater treatment plan. I don't know how we would modify, the COPE policies or whatever, but if we can meet the patient where they're at with what they can do, how they can do, that could be significant for program outcomes.
I can kind of address two questions that have come up at once. One person asked about the motivation for change, and then this more recent one. I just remembered that I actually had also offered for him to call in and do like a telehealth during his lunch break at work, and he was not interested in that either. So my impression was that he did not have much motivation for change, and the problem was just any participation in the group he didn't want to be a part of. But I couldn't never get him to open up enough to really just tell me what was going on in his mind. So that was, I actually blame the COVID thing for that. It was really hard for us when we were first making the change over to the group telehealth Zoom stuff to really have a personal connection with people in our medical management visits the way that we normally have historically whenever we bring people in. And so I've, since you weren't, here, Jennifer, that long prior to COVID, I can tell you that we, at least here, had very little difficulty getting people to not, or to get slots of their employment blocked off for a whole morning of being in person. But after we went to group telehealth, we couldn't get them to stay on for 30 minutes. They just didn't want to do it. And so we have, a lot of my cases presented recently have been about how can I be better at group telehealth? How can I get more engagement? And even more frequently, more recently, I've kind of somewhat gave up on it. We've actually been bringing them back into office as a group with social distancing and masks to try to recapture some of that magic we've lost.
So Ryan, you're talking about the not engaging in therapy group or your medication group?
Oh yeah. So we weren't. I think we were behind you guys at Chestnut Ridge in mandating video visits. So we let the audio group telehealth go on, and audio group telehealth is basically a bunch of people not listening and playing video games, and it was very, very disheartening to feel like I had to wait a minute to get someone's attention every time I called their name as I went through the group on the audio. So I really just I got the video late in the game, and by then I felt like I already had sort of lost a lot of the engagement that I would have gained had I been more aggressive about video in the first place. At first I was worried about video because of CFR 42 concerns, but when they relaxed those, I didn't aggressively enough force the video issue. But I'm really glad I did video, but I have to say, just within the first couple of weeks of starting to bring them back into office it was really satisfying to see, even without being able to hug people and having to wear masks. It was really so much more satisfying to do my job. It's a very different experience when they can come in. So I'm hoping COVID doesn't spike again and
This is actually what our didactic is on. I don't know, which is telehealth for MAT. So this is a good segue if people are ready.
I was just about to say, I hate to cut cases short or anything short, but we do unfortunately only have 1 hour. That goes by so quickly. But any further questions or comments, just feel free to chat them in. I can compile them, have them addressed and sent back to Dr. Morrison. But thank you so much, Dr. Morrison, for that excellent case. Thank you, everyone, for the comments. We have a great didactic lined up, Laura Lander and Emily Chilcote. So anytime you guys are ready, I'll pull it up for you, and the floor is yours.
Yeah, you can pull it up. And I just wanted to share my own experience. So are you going to advance these, Mitra?
I can advance them for you if you'd like, or I can give you remote control if you prefer that as well.
I'll have you advance them. So Emily and I have done some presenting, and you can advance this one. Actually, at WVU Medicine, we had a telehealth program here and had done quite a number of visits, and Emily had been part of that. So had been doing teletherapy as part of an IOP program for about 18 months before COVID hit. So she was way ahead of all of us in that learning curve. I, on the other hand, had only just started. So here's a slide just about the number of visits we had done. So we actually had some folks who knew how to do this before it happened. And then you can advance the slide. And then COVID happened, and we all had to figure it out because the rooms were empty, and many patients some patients actually felt like, oh, this is great. I don't ever have to leave my house, for those who had social anxiety or really struggled with transportation or coming in. You can advance it. And my own experience was, at first, I hated it. I hated it. I felt like I couldn't connect with patients. I felt like I was completely lost control of the group. People would disappear. People would leave the screen. People would be doing God knows what, off to the side like this. And it was really a struggle. And like many things, the more I do it, the better I have gotten. And I actually have had some groups, believe it or not, where I've felt real interpersonal connection in the group, which has been like, momentous, because I felt like I was not ever going to be able to achieve that on a video visit. But I'm here to say that it is possible. Emily already knew it was possible because she had experienced that, but I needed to experience it myself to believe it. And I do believe that, in crisis lies an opportunity, and we do now have a way of delivering treatment that many of us are much more comfortable with than we were 3 months ago. So I think that some tele will continue. We hope to continue it here, and for some patients it is better, and for some patients it isn't, and for some providers it works really well, and for some it doesn't. And so we'll all be figuring that out as we move forward. You can advance the slide. So there is, I have to move my boxes, I can't see. There are some real benefits to teletherapy. So it increases access for those in rural communities. It decreases barriers such as transportation, childcare, long travel times. Because we, like you guys, we would have patients traveling from, 2 hours away to come to treatment, which is really all day. In our experience, it has decreased no-shows and cancellations. I know that some folks have talked about that there has been a higher dropout rate during COVID as we've all moved to tele. And I think with some folks that's true, and for others, they've had good retention. It cuts down that travel time for both patient and provider, and it can be conducted safely and ethically. You can advance that slide. Now, some of the struggles are, concerns about, is it really as effective as in person? Those privacy concerns of who else is in the room. You can either sometimes see people who are in the room, sometimes you can't, but you can hear them. So there's concerns about confidentiality. Not all patients have the technology, so their frame freezes a lot, or they can't get on. Patient and provider discomfort, which was mentioned before. And the safety concern, there's the guy driving. So we've definitely had people joining Zoom groups when they are driving, which we basically ask them to pull over to the side of the road because it is not safe to participate in a Zoom group when you're driving. Retention issues, and then accountability issues. It's felt a little bit more difficult to hold people accountable. They report clean time or sober time. And are they really abstinent? If we're not doing urine drug screens, how do we know? So those kinds of accountability issues. You can advance that. So there is a fair amount of evidence. I know we're short on time, so I'm not going to spend too much on this. So there's evidence that it is safe. There's evidence that the outcomes are similar to in-person, believe it or not. And there's some evidence that patients really like it. So there's some satisfaction research out there that patient satisfaction is pretty high. You can advance the slide. And then there's research specific to substance use disorders. So we actually did a study here. Dr. Zhang did a study, and we found that both abstinence and retention rates were comparable with our tele and our in-person folks. There was a Canadian study that also looked at retention, and actually retention was better in the tele groups at 1 year. And then a systematic review by Lin in 2019, which is one of the biggest, most recent systematic reviews of telemedicine. And it was found that there was high patient satisfaction, and again, found to be as effective as in person. So the research is actually quite good to support this being an effective way to deliver services. You can advance it. So as you guys know, this is our treatment team and remains our treatment team in Tele, so that part hasn't changed. You get to see Dr. Marshalik there. You can advance it. And then the important thing, and I'm going to let Emily talk about this from here on in. So it is really important to orient the patient to the new way of doing therapy, because it is different absolutely than in-person therapy, and to have kind of a plan for that. So Emily, you can take over here.
Yeah, so if you have an in-person group that you're transitioning to tele, it would be a mistake to just say, oh, this is just our next week of our regular group. You really want to think of it as a total reboot. This is the first day that you held a group in each of these patients' homes. And you want to really do an orientation day, or part of your first 5 groups should be an orientation series to really help them understand the technology, because the better so everybody who's having trouble with engagement, a big part of this is that they don't understand that if they hold their phone this way, they see one person, and if they hold it this way, they can see everybody. And so we're not spending the time asking them, what are you seeing on your screen? Do you know where the chat button is? We're trying to jump past all the orientation stuff, and to just have our first telegroup feel like our next regular group. And you really have to think of it as starting over from scratch and introducing them to the space, introducing them to the new norms, and introducing them to the technology, because they will be more engaged if they understand how to interact with what they're seeing on their screen, and how to use any extra tools that your platform allows. And I think most of us skipped over that. And in COVID, so again, I had an unfair head start because I've been doing this for a couple of years in a very leisurely fashion. And most of you all it was like, okay, tomorrow you're going to be running telegroups, good luck. Most of us didn't take the time to orient ourselves to the technology to know what our platforms can do. And so slowing down and backing up and trying to think of this as a new thing for us and for them. I know we're short on time. Do you want me to hit every note here, or just the general?
Just the general, I think.
So maybe the next slide would be good. So yeah, when patients come to our buildings, we have lots of layers of helping communicate to them what our norms are in their own homes. They have a wide variety of norms. And so really making sure that you talk about tobacco, and that you talk about, bathroom breaks, and you talk about how many items of clothing you're wearing, and the big ones, but also the little ones too, as far as where are they seated, and are they running around also folding laundry, or and really spending some time asking a lot of them, and not just at the beginning of the group, but to catch it every time you see something in your screen that doesn't look right. Catch it immediately and talk to them immediately, because I think one of the reasons that we seem to lose people throughout group is we're talking to them at the beginning, and then we're sort of not talking to them again. If you can catch someone as soon as something seems strange, and bring them back into the conversation, get them back on the hook, that should help with engagement a little bit. And one of the benefits of our grant program that we have had is that we've been able to do slightly smaller groups. I think this is one of the big keys to group telehealth that many of us are missing right now is that we're still trying to run our 12 patient groups, and you can't even see and track everything that's going on in 12 little boxes, much less be able to notice a difference and pull people back into the conversation. So any chance that we get to make our groups a little bit smaller, that's going to help with engagement, it's going to help with monitoring, it's going to help with setting norms and making things feel real. Next slide. Yeah, so in my experience, which again, we got to go slow and steady and test things as we go, everything that we do in group therapy, most of the things that we do in group therapy were just as easy in a teleplatform as far as taking turns and introducing new group members and celebrating graduating group members and sharing things in rounds and asking people to generate spontaneous brainstorming solutions to problems, and sharing information with them, sort of psychoeducation materials and other visual aids. One of the biggest shifts you have to make if you really want to get people engaged is really think about how can I make this visually engaging as much as possible. So how would I do this in the group? If I'm in person and I'm having them put things on a piece of paper and throw it in a bucket, well, how do we do that via Zoom? Via Zoom, you do that by having them send you a private chat message with whatever they would have written on their piece of paper that day, so that you can see them and respond to them and do what you would like to do with them. Or I frequently use Sketchpad, which is a free online drawing program. So you throw up like an internet whiteboard and you say, okay guys, what's the biggest thing get in the way of your recovery this week? And you have them, either in a directed round, or they can shout out, or they can chat things, and I can write them up on a visual board for them to see in real time. And so I think for me, the biggest barrier to engagement is us changing our mindset so that we can think about, okay, how would I do this in person? And rather than say, oh, well, I can't do that anymore, say, how do I do it? How do I do this differently? How do I get the same process with using a completely different method? And so really utilizing the chat function, utilizing sharing your screen, sharing a puzzle, sharing, there's so many things you can create in a Word document. You can create like a Jeopardy board in a Word document. And when they guess a correct answer, you type it in real time, really thinking about how do we make visual representations of what we could have done in person. And it takes some time to really think that through. Can you go to the next slide? So these are the things that I really think are the advantages of telegroups over in-person groups, is sharing the visual images, videos, Word documents, fake little Jeopardy boards, all these visual things that I've created. I can share them spontaneously. When I'm in an in-person group, I've brought my folder to group, and whatever's in it is everything I have. With telegroups, you have the entire content of the internet that you can share spontaneously. So if a topic comes up in your group, or you want a topic to come into your group, you can pull anything from your own documents on your computer and anything from the World Wide Web to have at your fingertips. And that has been one of my biggest tools for getting people engaged, is people say, oh, I'm having trouble in a relationship, and quickly being able to pull some visual, some video, some free YouTube video, really knowing where your resources are and having them at your fingertips so that you can get access to them, even if you weren't planning on talking about relationships in group that day. And then the two other benefits that we had talked about, access, increasing access for folks who were not able to come to our in-person groups, and to a certain degree allowing a different type of anonymity or a different type of privacy. The grant that we were on allowed people to get into a group with folks in a different county. So in rural areas where people don't go to treatment because they're going to see their mom, their cousin, and their third grade teacher, getting them connected to other places other than their home community actually allowed folks to open up more in treatment in some of our experience. So I know we're super short on time, and I see questions and comments rolling in. What should we do with the last few minutes, Laura?
So I have been monitoring the comments and responding. So there have been suggestions about sort of doing a role play of this in future visits, which, if we only had somewhere around 12 people, we could certainly do. I think it's harder with a bigger group. But that's certainly something we can think about. And also, I encourage people to, as you're presenting cases, you could even present like a Zoom situation. Could be like a case presentation to talk about, this is what happened during the Zoom interaction. I didn't know what to do. This is what I did do. Or, that you don't have to think about individual cases only. You can think about group interactions as cases you could present here as well.
I really like that suggestion, Laura, because on one of our Zoom, we had someone just, his roommate had a bong, and they were all right there just starting to smoke weed. And I was like, what? And I didn't know what to do with it. And then the patient shifted, the camera right back to himself, right? So we just said, drug paraphernalia and using drugs, that's against our group rules. I mean, but man, I would have liked some feedback then.
So sometimes what we've done is we ask people to do a room scan, and that's really for safety and confidentiality. So we'll literally ask them to hold up their camera and like show us, who else is in the room, and they'll do a room scan. Does that mean somebody's not going to walk in the room? No, but it brings their attention to the importance of having a private space. Now, as was pointed out in one of the chats, like not everybody has a private space, and they cannot get time away from their children to join a Zoom group, which is a problem. And it may mean that it doesn't work. Often, I've found that often women have trouble setting that boundary for themselves, especially if they're in their own home. If they have to say to their partner or their mother, I got to go to this other place, you take care of my kids, that's a little bit easier to do than if they're home. Often they can't get the support if they're in their own home trying to take care of themselves and be in a therapy group. The other thing is when you see something happening, and this is what we do in regular groups, is to sort of recognize it as it's unfolding. So, Ryan, I'm noticing that you just popped off the camera there, and I just want to remind you to keep your camera, just calling people out on when they're deviating from the norms in real time, in a gentle, kind way, to help kind of norm people as you go, especially in the beginning.
Thank you so much. We did get a quick question. We have about 1 minute left, but I think we can squeeze this in. The question was, could you describe how you encourage patients to interact with each other on a group video call?
Emily probably has a really good answer for that.
Yeah, so there's about 87 ways. How many seconds do we have? So I sometimes will do the old thing where you ask somebody a question and then you make them pick who they want to hear from next. So they have to be like, wait, who's in this room and what are their names? I want to hear from this person that, or just really insisting to do rounds that here's a question we're going to, and when you're doing rounds, you have to be more directive. In an old fashioned in-person group, you say like, wow, who's got an answer for this person? In Tele, you have to say, Bob, can you answer this question? Sheila, can you answer this question? Don, can you answer this question? And you have to call them out by name all the time to get them to be engaged and doing that as much as you possibly can to every 5 minutes.
That's excellent. Thank you so much. And thank you, Laura and Emily, for that excellent didactic. I apologize, we ran out of time. I always feel like the hour is way too short for this session. So thank you all so much. One quick announcement, our next session will be on July 13th, and Jeremy Husted is providing our didactic on combating stigma. So we hope we can see you all there next time. Thank you, Dr. Morrison, again for that case as well. Laura, I'll probably reach out to you at some point for that role play idea. That's a great idea. We can coordinate something for that.
Sure.
Great. Thanks, guys. See you next time.
See ya.